You know, in the world of the nurse practitioner, the things that have always kind of plagued us from a medical malpractice risk continue to be the same, such as delay of diagnosis or failure to diagnose. That remains one of the leading causes. We're seeing increased liability in terms of medication errors and drug to drug interactions and how that all plays out, particularly around drugs like your anticoagulants. You know, I have 5 cases that I've worked on just recently involving warfarin. And so medication interactions, average patient coming out of a skilled facility, Medicare patient on 11 different drugs. So this is definitely a concern of ours. And I know we're going to talk a little bit about this, but scope of practice in the world of the nurse practitioners are getting additional certifications beyond family or adult. They're getting dermatology, they're getting cardiology, they're getting ER. What does that do to scope of practice for the generalist like me? At what point does what I'm doing become really a psych entity and not just a family NP? And the more specialized we become, and I've heard this from attorneys around the country, that this is really becoming an issue. Did that belong in family practice, or should psych have done that, for instance? So that's really becoming an issue for us. And then I just have to say, in primary care, we're being asked to do more, to see more. Our portal messages that come in exceed over 1,000 on any given day in primary care. And then over 500 to 1,000 phone calls, 16-minute primary care visits, and the average patient discusses 6 different items in that time. So all of this goes to lead into increased risk, and more NPs are leaving primary care, moving out to specialty. And what does that look like in terms of standard of care? Are you held to a cardiology standard if you're working in a cardiac facility? So those are some of the issues that we are reckoning with at this point in the world of the NP.